Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You now have 90 seconds to read questions 31 to 36.
It is important to realise that 83% of people who commit suicide or attempt suicide have had contact with a doctor within a year of their death, and up to 66% of people who commit or attempt suicide have had such contact within a month of their death. Therefore, with better prevention techniques, these figures could be reduced. We can divide suicide prevention into 3 categories, which are primary, secondary, or tertiary. Secondary suicide prevention aims to decrease the likelihood of a suicide attempt in high-risk patients. Tertiary suicide prevention occurs in response to completed suicides and attempts to diminish suicide in a particular geographical area or in a particular age group. I would now like to look at secondary suicide prevention in more detail. Secondary suicide prevention is particularly important, but not always given the attention that it deserves, in part because research into secondary prevention is only just starting to be applied to clinical practice. Now, from a clinical perspective, suicide is often difficult to predict due to its complex nature. The 3 major risk factors that contribute to suicidal behaviour are biological, psychological, and proximal stresses, which are recent events that can lead to increased suicide risk. Firstly, there are biological risk factors for suicide, which include low blood cholesterol levels, medical or neurological illnesses such as multiple sclerosis, stroke, Huntington disease and epilepsy, cigarette smoking. Secondly, there are psychological risk factors which include a childhood history of physical or sexual abuse, aggressive personality traits, low self-esteem, and poor access to psychiatric treatment. Thirdly, there are proximal stresses, or the recent events that can lead to increased suicide risk, and these include relationship problems with a spouse, partner, or loved one, financial troubles caused by unemployment or large amounts of debt, a family history of suicide, major depression, and drug abuse. The clinical evaluation of the medical and psychiatric history of a patient and of their current state is the crucial and essential element of the suicide assessment process. It is important because it enables the identification of risk factors in order to determine the patient's immediate safety and the best setting for treatment, and also to develop diagnosis and treatment strategies. Psychiatric illness is a major contributing factor to suicide risk, with mood disorders such as major depressive disorder and bipolar disorder being associated with about 60% of suicides. Indeed, psychiatric disorders are diagnosed in more than 90% of completed suicides, and more than 80% of these psychiatric disorders are untreated. Thus, the recognition and treatment of individuals with psychiatric disorders, specifically mood disorders, are essential components of secondary suicide prevention. In addition, the subjective rating of the severity of depression is one of the most powerful predictors of future suicidal acts. Therefore, assessing and managing depression, as well as being aware of the suicide risks in psychologically, medically, and neurologically disordered individuals, is an important aspect of secondary suicide prevention. Consequently, physicians need to be taught to recognize the association between mental disorders and suicide. Additional information about the individual who may be at risk for suicide, such as medical and psychiatric treatment records and toxicology screenings, should also be incorporated into the assessment. Equally importantly, clinicians and other professionals in a position to offer help should not hesitate to ask patients about suicidal ideation because, while it may seem surprising, patients will often talk frankly about their suicidal thoughts and tendencies if given the opportunity. Failure to ask about suicidal ideation may be related to the health professional's discomfort with the topic, lack of time, or lack of skills in this area. Clinicians need to overcome these obstacles to provide appropriate care to their patients. What are the most effective secondary suicide prevention strategies? In a recent systematic review of suicide prevention strategies, Mann, along with other researchers, found evidence of effectiveness in 5 secondary suicide prevention methods, including pharmacological interventions, psychological interventions, follow-up care, reduced access to lethal means, and responsible media reporting of suicide. Antidepressant medications are the most widely used pharmacological interventions in secondary suicide prevention, but studies of their effectiveness in reducing suicide attempts have had mixed results. Among adults younger than 25, the effect of antidepressants seems to be neutral on suicidal behaviour, but it seems to reduce the risk of suicidal behaviour in the elderly. Thus, the relation between antidepressants and suicide needs further studies before this class of drugs can be safely used for the secondary prevention of suicide. In terms of psychological interventions, suicidal patients often benefit from therapies that address the repetition of suicidal thoughts and behaviours, and other factors commonly associated with suicide. Better psychological and pharmacological treatment of depression and alcoholism also appears to decrease suicide rates. Social factors that should be addressed in follow-up treatment include availability and willingness of supports within the family. Support individuals who should be contacted about the suicide risk and follow-up arrangements include general practitioners, private psychiatrists, family and friends. Some interventions, however, such as telephone and psychosocial follow-up, have shown no difference in suicidal ideation when compared with standard aftercare. Many studies show that suicides by particular methods, for example, firearms, domestic gas or pesticides, decrease after the introduction of legal restrictions that reduce access to such means. This reduction in suicide rates is particularly influential in regions where the specific means of restriction correlates with a common method of suicide. For example, in the UK, the reduction of carbon monoxide in domestic gas since 1958 and the reduced availability of analgesics since the mid-1990s have both decreased UK suicide rates. Finally, many studies have exposed a need for a decrease in reporting of suicide and for responsible reporting. Media blackouts in reporting suicide have coincided with a decrease in suicide rates because reports of suicide in the media tend to glamorize suicide for vulnerable individuals. The internet is also of increasing concern, with blogs and chat rooms providing accessible instructions for suicide. For these reasons, guidelines have recently been produced for the responsible reporting of suicide. Despite our increasing knowledge about secondary suicide prevention, there are still many gaps in the research, and looking to the future, thorough evaluations and appropriate treatments of patients with depressive disorders and other psychiatric illnesses should help to improve the efficacy of secondary prevention of suicide. But it is also clear that more research into new approaches for the prevention and treatment of suicidal behaviour remains essential.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
New research from the Perkins Institute at the University of Sydney claims to have found the diet that boosts FGF21 levels. One of the lead scientists on the study was Samantha Solon-Beat of the Perkins. Welcome to the Health Report.
Thank you for having me.
So what is this stuff, FGF21? I mean, it's almost eye-crossingly complicated from the look of it.
Yeah, it seems complicated, but it's actually not. And recently, there's actually been an immense amount of interest in fibroblast growth factor 21, or FGF21. And this hormone has actually recently been called this fountain of youth hormone, which we know can be influenced by diet. And the reason why FGF21 is so interesting is because high levels of this miracle hormone, as it's called, has actually been shown to play a huge role in influencing appetite, improving metabolic health and immunity, and even extending lifespan in mice.
Now, something that sounds so good to be true is usually too good to be true.
At this point, there are no adverse effects shown with increased levels of FGF21. In fact, a lot of studies are now being done to investigate FGF21 as a therapeutic target for the treatment of diabetes and cardiovascular disease.
Let's just double back, Sam. A year or so ago, we had Steve Simpson, who's the director of the Perkins Institute, talking about this 25 diet study where they studied 25 diets in mice to see if you could replicate the life-prolonging effects of a low-calorie diet. We're extremely low-calorie diets in some animal species, in fact all animal species, it seems, apart from humans because it's not been proven yet, increases life expectancy or lifespan. Is the FGF21 really the heart of this matter?
We think it actually could be. Certainly in this study, we've shown that a diet low in protein and high in carbohydrate is the most effective way to increase levels of this miracle hormone. And that this diet was also associated with several markers of improved metabolic health in mice.
So tell us a little bit about this study.
Well, what we actually did was performed a really large mouse study, as you said, where we took 858 mice and offered them a range of different diets to see how macronutrients, such as proteins, carbohydrates, and fats, as well as total energy, could interact and influence levels of FGF21.
And you found?
And we found exactly that we could use diet to increase the levels of this FGF21 hormone, and that a low-protein, high-carbohydrate diet was the most effective way for increasing this miracle hormone.
And what effect did that miracle hormone, I hate using that word, that phrase, but what effect then did the hormone have on these mice, or were you able to separate the two?
We were actually able to show that the exact diet that increased FGF21 also improved things like insulin sensitivity, glucose tolerance, blood pressure, and blood lipids, even though the animals were a little bit fatter.
And how do you know that was anything whatsoever to do with the FGF21, your so-called miracle hormone, and rather than it just being an accident that it was raised too?
What we did was plotted FGF21 using the geometric framework, which is a nutritional modeling platform that helps us tease apart the role of nutrients and calories. And if you line up all the surfaces, the response surfaces in this framework with FGF21 and all the metabolic outcomes, you can clearly see that there's a specific area in the nutrient space that coincides with increased levels of FGF21 and several metabolic benefits.
And what kind of carbohydrate, and what happened with fats?
In this study, fat did not appear to have an effect on FGF21 levels. It seemed to be low protein was the primary driver, and that the highest combination was with a low protein, high carbohydrate diet.
So what does FGF21 do to the body?
And that's a really good question. And that's really the next step of our study. We want to understand how FGF21 signaling works in response to diet to mediate all these beneficial outcomes.
Do we know that there are any medications affected?
At this point, no.
It seems that it goes up with starvation, it goes up with overfeeding. There's lots of things that influence it. Did the appetite of these mice change? Do they eat more or less when the FGF21 goes up?
Oh, that's a really good question. See, this is one of the things that we were able to reconcile in our studies. As you mentioned, a whole range of literature in previous studies have shown that FGF21 is elevated in many paradoxical conditions such as starvation and obesity, high intake of food and low intake of food, as well as in insulin resistance and in insulin sensitivity. So what is going on here? Using the geometric framework, we were actually able to tease apart these findings, showing that reduced protein intake is the primary driver of FGF21.
Okay, so what happens in mice does not necessarily happen in humans. How do you know it makes any difference at all in humans?
Oh, I'm glad you said that. We've actually published work just this year showing that FGF21 levels in humans is also increased by a low-protein, high-carbohydrate diet. And of course, this is really exciting because it tells us that the work that we do in mice can be directly translatable to humans.
So is there any evidence at all that FGF21 has the same beneficial metabolic effects in humans as it has in mice?
Yes, there is definitely evidence to suggest that high FGF21 levels is directly related and associated with several benefits of metabolic health in humans as well.
So we should put it in the drinking water then, do we?
Yeah, probably. That seems to be the case, yes.
How would it work? I mean, obviously a hormone like this is probably destroyed in the stomach. This is not something that you would give directly to people, I assume, in the therapeutic context?
At the moment, it's difficult to do chronic administration to humans. So what's happening in terms of drug development is trying to develop mimetics of FGF21 and analogs. So not exactly administering this hormone per se, because it would require chronic injections or chronic administration.
So almost nothing that's touted as a breakthrough or a miracle by scientists turns out to be so. What are your modest expectations of FGF21 in humans?
Well, in humans, we actually think that FGF21 is extremely promising. We think that, at least in humans, we've shown that FGF21...
So a treatment for type 2 diabetes?
Absolutely.
That sort of thing?
Yes. We've shown that humans seem to respond in the same way as mice. So this could mean that we could tailor our diets and our nutritional guidelines to generate a range of benefits from FGF21.
Is it too blunderbuss? You're describing something that sounds blunderbuss rather than targeted. You're just spraying an effect rather than targeting an effect. If you can do anything with it, it's going to be a very wide set of actions which you're going to find hard to control, isn't it?
At the moment, everyone is very interested at FGF21, but no one really knows its mechanism of action. And it seems to be a race at the moment. How does it work? What turns it on? What switches it off? And what can we do to find out more about it? So at this point, I think it's a really hot topic and everyone's racing to find out the answer.
And you hope you'll be first.
Hopefully.
Sam, thanks for joining us on The Health Report.
Thank you so much.
Samantha Solon-Beat is a researcher at the Perkins Institute at the University of Sydney, and on our website we'll have a link to our previous interview on the diet and longevity study.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
That is the end of the listening test.